Well, good afternoon, everybody, and apologize for the brief delay getting started this afternoon. My name is David Skok. I am the founder and CEO of The Logic. I'm delighted to be with you today for such an important topic, which is disruption and recovery, AI's role in a post-pandemic healthcare. We have a terrific panel on this topic. Obviously, the COVID-19 pandemic has accelerated the digital transformation of healthcare in Canada and around the world. And innovations in artificial intelligence and machine learning are at the core of this transformation and could play a significant role in our future economic recovery efforts. So lots to dive into. But first, before we start, I want to give a chance to introduce you to our delightful sponsor, Microsoft Canada, with special remarks from Dr. Helia Mohammadi, who is Microsoft's chief data scientist and healthcare industry lead, clearly someone who knows as much, if not more, about this than anybody on this panel today. So, Dr. Helia, I'm wondering if you could start us off with an introduction and also, tell us a little bit about Microsoft and how it's viewing a post-pandemic recovery.
Thank you, David. It's a pleasure to be here with you and our panelists today. And thank you to everyone for tuning in and joining us for this discussion. First and foremost, I would like to thank our healthcare professionals and healthcare decision makers for working so many long hours to keep us all safe. Although this pandemic has created considerable challenges for our healthcare system, it proved that there is really no shortage of visionary and innovative solutions designed and developed to overcome this crisis. There have been extraordinary advancements across our healthcare system as hospitals and health authorities shifted towards a rapid adoption of new technologies that enabled them to share data and information at rapid speed in order to fight this battle together and deliver better care and more personalized care. At Microsoft, we've been closely collaborating with our customers and with our partners since the very early stages of the spread of this virus. And we've been trying to solve great challenges through designing data sharing platforms, leveraging AI and cloud solutions, and putting privacy and safety measures and the health guidelines in place for our healthcare organizations to better support patients and also their care team. We collaborated with many health organizations, including Providence Healthcare and the computer vision researchers at the University of British Columbia to develop an AI-powered solution that uses IoT technology, or cameras in this case, to build PPE monitoring and crowd counting solutions on Microsoft Azure. And this is while protecting the privacy and security of patients and staff at their facility through IoT edge processing was a key focus, where the data is actually processed and analyzed only at the camera level. And you will shortly hear more about this collaboration from one of the panelists. The Jewish Hospital in Montreal is another example that they are using the Microsoft HoloLens to bring a team of experts and healthcare professionals to any COVID-19 positive patient from a distance. Using this technology, one healthcare professional is equipped with PPE, will visit the patient's bedside wearing the HoloLens and will deliver real-time updates, including x-rays, charts, other test results to the care team, enabling them to see everything through the HoloLens, minimizing the level of their exposure to COVID-19. Another incredible collaboration I'd like to share is DNA Stack's COVID Cloud. Basically is a solution that on the past Friday was announced by Premier Ford. And it's a partnership between DNA Stack and Public Health Ontario to leverage their cloud it's called COVID Cloud Data Bank and their analytics solution, which is powered by Microsoft Azure. It's really in order to deploy the very first early warning system in Canada that can track COVID-19 variants and pattern of spread. They will be deploying the solution rapidly over the coming days so that Public Health Ontario and the Premier's health leadership team can immediately incorporate insights into both their health and economic policy decision making. On the other hand, University Health Network and BC Cancer are two of the first cancer research centers to use Microsoft Cloud for their machine learning, compute and storage requirements to perform their genomics research. BC Cancer recently moved 1 petabyte of its genomic data to Azure to ensure a trustworthy and secure and scalable data solution, and to gain the computational power they needed to process that data. This collaboration will lead to cancer treatments and research breakthroughs. And while on the other hand, UHN was able to run their machine learning workloads that could take months or years only in a few days or weeks. During this past several months, I've been especially inspired by the ways government and healthcare organizations across the country are quickly reinventing how to operate. Many of these changes put in place today will help medical professionals deliver personalized care to Canadians in very new and innovative ways. And these solutions will live well beyond this pandemic, for sure. And Canadians living in remote communities as well will have more access to care, and especially an AI-powered translation tool, as we recently announced, includes Inuktitut language, which is the language spoken among 40,000 Indigenous population. Also, basically, those managing chronic care issues will be empowered to manage their own treatment with more access to their own data. We believe that no one company or government can solve a challenge of this caliber on their own, and we are very proud to be supporting the most innovative companies here in Canada and also across the world to manage and fight this pandemic together. Thank you, and back to you, David.
Great. Thank you very much. And what a great kickoff. Let's not waste any more time and go right to our panelists. I'm going to quickly introduce them. We have Soyin Kim, Director of Digital Products at Providence Healthcare in British Columbia, Katie Yam, General Manager of Founder Fuel at Real Ventures, and Dr. Fahad Razak, a physician and scientist at St. Michael's Hospital and the University of Toronto. So we're all over the country here. We at least have Montreal, we have British Columbia, and we have Toronto. Katie, I was wondering if I could start with you. First, I find when we get into these conversations, there's a lot of jargon that sometimes happen. And just as a level set for everybody who is joining us today, artificial intelligence itself is even a debatable term. As someone who has worked in this space for quite a while, could you provide a little bit of a standard definition of sorts on what we mean when we talk about AI?
Sure, David. Pleasure to be here with everyone. I think AI, there's such a big range with regards to the definition. So for many people, they're not familiar with that. It actually was a term coined in 1955, and it's just simply on a branch of computer science that helps to simulate intelligent behavior in humans. But lately, the reason why we're all talking about all this is it's not just your calculator or your spreadsheet that is technically an AI, but specifically in machine learning and really the subset, which is deep learning. So everything we've talked about, neural networks, just understanding how the brain works and that they're self-learning. And these algorithms are training on data, like tons and tons of data, to actually teach itself to make decisions more autonomously. And that deep learning has been driven by many Canadians that we know, Geoffrey Hinton over in University of Toronto, and also Yoshua Bendra in University of Montreal here in Montreal. So that's kind of the subset. I think most people are why it's so hot right now. Definitely the explosion of deep learning. And Canada has a lot to be proud of, having won the Turing Prize in this recently last year with Geoffrey Hinton and also Yoshua.
So there's a lot of innovation. It's a rapidly changing space. Now we're facing an enemy, this virus, that is probably more innovative and rapidly changing than we are. I'm wondering, Soyin, if you could give us a bit of a step back primer on how Canada's AI industry and more broadly how the Canadian tech industry has worked with healthcare practitioners during this crisis.
Yeah, absolutely, David. I think the partnership and then really the community coming together for a rapid development of the solution in our fight, collective fight against this pandemic, I totally see that as part of our legacy, as part of COVID. There's a couple of created and partnership we established at the global level. So the Helia mentioned briefly in her opening the PPE solution, PPE monitoring solution that we have partnered with Microsoft. So we work very closely with the Helia and her team at Microsoft Canada, as well as the teams at the Redmond office at Microsoft headquarters, and also the researchers from computing lab from UBC. So that was a solution that was rapidly developed and then implemented during this COVID for the purpose of PPE monitoring and social distancing monitoring. So it was very important, it played a very important role from a monitoring perspective. So that was the role that, especially in the first wave of COVID, and then, and thinking about infection controls and, how do we best monitor? So making sure that people are wearing PPE, making sure people are social distancing, which is very important, as we all understand. So these are the roles that are fulfilled by the people. So we have a dedicated people and personnel who are, we call them PPE spotters. So it was, I guess, in the beginning of the wave, it was very, human resource intensive, and then there was an incredible amount of effort put together by this team, and not only just the monitoring, but provide that education to people, patients, and the staff that it's so important that you wear PPE, and it's so important that you do social distancing. So this opportunity came about as we're moving into a second wave. That the monitoring takes a lot of time, as you can imagine. That it's very, very there's no one who can be there 24/7. Who can do that monitoring and then provide that education. So this PPE monitoring solution, essentially in terms of technology stack, it's an IoT camera and enabled with AI. And then as Helia pointed out, that because of privacy, the design that we picked was, it was leveraging edge compute so that we're not moving patient information all around, in and out of cloud. So the inference itself was done on the cameras itself, but it came about as an opportunity to augment some of the great work that was already done in terms of ensuring PPE is properly done, and then social monitoring is properly done within the hospital. So we have deployed the solution in partnership with Microsoft at the radiology ED, which is one of the busiest places in the hospital, as well as lab. So that's how it came about. So I think that it's really speak to the partnership element, the partnership that are happening at the global level. And I was very pleasantly surprised how quickly we could come together as a community. Another example is that we partnered with the United Nations to develop and deploy a solution on the chest X-ray model to help with some of the COVID pneumonia diagnosis and operations around that. So as you know, that the COVID really represent, and the key issue that was, that came about is really the capacity. So we don't just treat COVID patient. I mean, there's the surgery still needs to be done, and then there's HIV, and then there's a whole bunch of issues still stay. So COVID really represent, it was just on top of everything else. Hospitals, already busy place. But so it really challenged us, just looking at, what is the capacity now, and how do we fundamentally increase that capacity, both diagnostic and operational capacity dramatically. So it was really that capacity issue. So we looked at the number of solutions, and PPE monitoring was hugely helpful. The other solution was that the sort of the partnership we've done with the United Nations together with Algorithmia and also SFU, which speak to that sort of the global partnership that came together, again, very, very quickly to increase our diagnostic and operational capacity within our hospitals.
Okay, so Dr. Hazak, we have the venture capital community, we have money, we have capital flows, we have the partnerships at the United Nations. So you mentioned. You are, forgive me for pinning you as the healthy skeptic here, whether you want to be or not, but I would love to know, at the hospital, how is all of this being received when people are on the front lines dealing with patients? And I'm curious, and obviously examples of where it's worked, but really, the cynical person in me would say, this is all great that it's happening here. I'm in a war zone. I'm fighting on the front lines. and all of this stuff is nice, but it doesn't impact my day to day. Does it?
Yeah, so I'm gonna be a partial skeptic, but I'm also gonna be a partial booster, David. So I'm not gonna go full skeptic on this. I would say that so I'm a frontline general internist. We care for the majority of patients who are admitted to hospital with COVID. About 80% of patients end up on a general medical ward, which is the kind of medicine I do. So I've spent many weeks over the last year on the wards caring for COVID patients. I can tell you that there's been two major ways in which our care has improved that I think will have a lasting legacy. The first is the rise of virtual care models, whether that is virtual access to a specialist, using virtual devices like an iPad or an iPhone or other tablet-like devices within patient rooms, monitoring of patients so that we don't have to go in and out frequently, but which will have lasting benefit because there's ability now to continuously monitor a patient. So all of these virtual care models, I think, have changed more rapidly in the last year than I've ever seen at any time in my career. And they will definitely outlast this pandemic in a very positive way. The other really positive way that I think change has happened is system integration. So Canada has some of the lowest per capita hospital beds in the OECD, and Ontario within Canada has relatively low numbers relative to other provinces. So we were already an extremely constrained resource before COVID hit. You may remember news coverage of things like hallway medicine. And COVID forced us to think about system integration in a way that probably should have happened earlier, but there's nothing like the impetus of the pandemic to force you to do it quickly. And that kind of system integration means thinking about individual institutions, hospitals as being part of a network, and how do you share load between them. So those are two really important ways that I think there's going to be a lasting positive legacy. I am also an AI researcher. I'm primarily actually a researcher. And I would say that my interest in data integration and applying advanced analytic models from a research perspective has improved. Things have improved dramatically in the last year. The access to integrated data sets, the rapidity at which data becomes available has improved dramatically. The translation of those models to the direct frontline physician. So I develop models in my lab. Using those models at the bedside with a patient, that step has not occurred. And I don't see any significant advances, at least in the last year, to breach that divide. So there's that final deployment problem, which often exists with a lot of technologies. They're great in the lab. They can really do very accurate prediction or other kind of risk stratification. How do you actually get them into the hands of each physician at the bedside? That step hasn't really occurred.
Is that a cultural gap? Is it a confidence gap? Is it just a technical process gap? Where do you see that falling short?
It's both. So the kind of modeling and the way that risk prediction works is not taught in medical school. So there are newer generations of physicians who would be more comfortable using these kind of technologies, but the ability for the vast majority of physicians to use them is not something that they're well educated yet on how to use. I'll give you an example. Some of the most common conditions that we deal with in hospital, we still think about risk by counting risk factors on our fingers. So for something called atrial fibrillation, which is an irregular heartbeat, we'll count on our fingers and we'll say, do you have high blood pressure? That's a 1. Are you over the age of 65? That's 2. And we'll count. And if you reach a certain count, we consider you to be high risk. Now that is diametrically opposite from the capacity of what these advanced analytic models could do with all of the data that's available. And so there is a bit of that cultural gap. But importantly, there is a major technology barrier, which is that the conventional electronic health records that are used in hospitals and family medicine clinics, they don't have the ability for the majority of physicians yet to give you any kind of real-time prediction. So they can't comb through the data on that patient and deliver a warning flag to you, say, this patient is very high risk for deteriorating and going to the ICU, or this patient has a high 1-year risk of cancer, or this patient's COVID may be worse than other patients. So that technology barrier of taking the electronic tools we do and directly translating them into prediction that I would use right then to care for patients, the technology is not there in the majority of healthcare settings.
Katie, you wanted to jump in?
Yeah, that's really interesting, Farhad. I really love that perspective because it's like on the ground. It's really far from what I do. But so just a little bit of background for those. I spent 3 years at Element AI, and we kind of grew a lot of arms into AI in Canada. I'm curious to know, so I agree with you that that the data is dispersed and you can't make those on-time calls because most of the systems are very legacy systems and they're not speaking, and it's very hard to like aggregate and normalize that data to do any significant impact. But I was sticking to the point that you said earlier, like frontline, and I've seen some of the technologies with regards to like diagnosing at a distance on like open wounds, for example, and maybe not specifically to COVID, but I've seen where immediately on the ground, someone can use their iPhone and then take a picture of a wound, and with computer vision, it's able to diagnose like what the risk, what the things are, and it's actually deploying out into the nodes, care that normally would have required someone to come into the hospital or come to a clinic and actually see a doctor. And there's so many of these, like this is one example, there's many more. Like, are those, when you mean you don't see it at the front lines right now, like what were you inferring, if I can ask, like what would you like to see that you're not seeing?
Yeah, it's a great question. It goes back to your definition in some ways of what artificial intelligence is. So I would say on the healthcare side, another way of thinking about artificial intelligence from a definitional point of view is things that take over tasks that normally require human intelligence to sort out. So it's not really just prediction, it's taking over these cognitive decision-making tasks that are very difficult. There was a recent review by Eric Topol, who's one of the leaders in AI in medicine in the United States, that looked at areas where AI has directly translated into clinical care. And they're really limited to two major areas by and large. And they're related to image processing. Yeah, so chest x-rays, scan reading, et cetera, or wound image processing, like you mentioned, or reading of things like pathology slides. So again, an image-related file. The reason why that's important to think about as a limited subset is that kind of decision-making does not represent the majority of what we have to do in clinical medicine. So the majority of what we have to do in clinical medicine, there's a couple of problems. The first is that there's an incomplete data space. So if you have a chest x-ray in front of you, arguably everything that you need to make a decision is within those image pixels. But that's not what frontline care looks like. Frontline care is we see a patient, we have a blood pressure reading that's over here. They tell us something about how they're feeling. There's some visual interpretation we're making as we see the patient, the color of their skin, how their nail beds look, things like this. Bringing that information into some kind of clinical decision-making, there's no examples that I know of yet anywhere globally where that has entered frontline care. And the majority of what we do clinically is that kind of decision-making and not image processing. So I think image processing advances are remarkable, what AI has done. But that kind of direct clinical decision-making that we have to do day in and day out, that kind of frontline application hasn't been done successfully yet, to my knowledge. Would love to see it, but.
So the integrated approach of like all the different silos, the patient history, the different clinics, the different specialists, like there's no one-stop shop of that. Yeah, I agree. I agree on that.
Yeah, correct. And a lot of that information is not digitized, importantly.
No.
A lot of that information is not digitized, so you can't even develop models yet.
So Ian, you wanted to weigh in?
Yeah, absolutely. I think I totally hear what Fazaz is saying in terms of there's definitely next steps and barriers in terms of fully putting AI into use. In terms of directly assisting clinical sort of practices and diagnosis. But I still do see there are many areas where AI can make a direct impact and then meaningful impact to assist with some of the operational issue and the capacity issue, which, as I mentioned before, the COVID represented the significant capacity issue. It's basically everything that's going on, and on top of everything else, this is significant load, to that. So in terms of sort of operation, I mean, this is there in terms of many uses of AI. This, I talked about the PP monitoring solution, which is really to help with the operations and monitoring, and those are the operations managers. So there's, nurses, and then the physicians, and then, clinicians, but also, the porters, and then operations managers. And then there's a number of different areas where AI can make a significant impact and then very meaningful impact. So I just wanted to point that out. In terms of the regulatory front, and this is about, how do we sort of put AI into practice in a meaningful way, especially, and for the purposes of directly assisting a clinical decision. I've seen some examples of the work that Health Canada's approval of AI-assisted sort of care. There's a class 3, and I've seen a number of local examples who've actually gone through that process. So I think that's a step closer and towards, and I think there's been some improvement there. in terms of how do we best put this AI into practice, especially in the areas of assisting clinicians.
So, Ian, you touched on something that I'd love to get to at the policy level. Pre-pandemic, there was every conference I would go to, or everybody I talked to in the biotech, life sciences space would say, the biggest issue we have with our company is procurement. At the provincial level, at the federal level, in Canada, we have more success in the U.S. Getting customers there than we do within Canada. You're someone who is, navigating this public-private partnership space. Is the pandemic in some way catalyzing government to want to play ball more with tech innovation?
Yeah, absolutely. I think that's another important point, and I totally see that as part of the legacy. So I think driven by needs. So I think the government and the hospitals like ourselves, I think more and more we recognize that there has to be this the data infrastructure, a foundational data operation pipeline that requires investment in order to really take advantage of some of the potential that from AI, and also really tap into the data that we have, right? So that's one area that Providence Healthcare has made an investment that we kind of recognize as part of this partnership, working as part of this ecosystem and with partners, that we have to recognize, I mean, we're not going to do all the development ourselves. We have to work with partners. So number one is that how do we sort of share this data with partners and researchers and teams like Helios and others and Microsoft? How do we sort of share information and securely and in a safe manner? So we have to think about the patient privacy and security. So those are the areas that actually requires the build or the creation of foundational data operation pipeline. So we had to make an investment. So things like guardrails, right? And things like encryption, and things like de-identification pipeline, right? So we cannot eyeball this and do this manually. We had to create a systematic pipeline that actually meets the compliance requirement, so that we feel safe and secure to share this data with our partners. And deployment is another topic. That's another area that we recognize. Hey, AI isn't just about the algorithm, right? You have to look at it, from the perspective of the overall data operations to really tap into its benefit. And so in terms of, I guess, the systematic pipeline, and then the foundational data operations infrastructure, that's an area that Providence as an organization had recognized, and we had the made investment in. And then and it's an area where we see it's a legacy that's going to serve us well, not just during COVID, but COVID and beyond, to really help tap into some of the potential that AI holds.
You mentioned data security, and I do want to come back to that and privacy, and I know Katie wants to jump in there, but before we do, I do want to go back to the hospitals working with companies piece and to see just how it's going. Maybe Dr. Razak, I'll ask you, are hospitals more willing at this point to be customers?
Yeah, I think they definitely are. We have interacted with for-profit companies in various aspects of healthcare provision more in the last year than I've seen historically. I do think culturally Canada is very different about this. So I spent almost 5 years training in the United States, and there is, for good or for bad, there's negatives to this as well. There's a tighter integration between the private sector and healthcare delivery. Hospitals are for-profit institutions in the United States. Clearly in Canada, that's not the model that we have. And so when you have a system that competes like it does in the United States, there is a strong incentive at the hospital leadership level to look at private industry solutions for problems. That's fundamentally not what we are in Canada. And again, philosophically, I don't disagree with Canada's position, but every philosophy has some limitations. And one of them is we are slower to uptake innovations from the private sector within healthcare delivery.
Katie, actually, having lived and worked in Boston as well, I vividly recall covering something called EPIC as it was integrated into Harvard, Partners Healthcare, which is one of Harvard Medical School's programs, and the tech debt, both from the doctors who didn't know how to use the system, along with the integration of new platforms. I mean, Dr. Razak mentions the idea of having artificial intelligence in these enterprise systems. Where, as someone who's tried to integrate these platforms or seen through the companies that you work with, how much of a barrier is the technological integration of these new applications into legacy systems?
Question for me?
Yes.
Yes, sorry. I think above and beyond, I think I really like the term that Soyin used about data operations. I don't think we actually talk about that enough. A lot of stuff is in the back room, and it's not talked about how the ETLs work, or how the data is normalized and prepared for these AI systems to work. And I think a lot of items that we've seen in the last couple of years of trying to deploy is, we do a very quick proof of concept, a POC, and it works. It works really well. And I think working with companies in specifically AI, they don't really always work in production. So it's amazing to see you have this great POC. It works pretty well on a subset of data, and then you go to roll it out in production, and it's as if you're reinventing the wheel almost on some of this, and the data doesn't act the way that it did in the POC. So a lot of stumbling blocks I've seen have been in deployment, in getting it up to, because when you open it up, open the gates up, if the data operations aren't really there. And I think the bigger concern for a lot of people, especially I would say in Canada, especially in healthcare, is people are putting protocols in place for the data security, and we are moving at light speed because of COVID. It's forcing everything to go really quickly. But at the same time, I'm seeing companies that are presenting me ways that data is being hacked in ways that I've never even seen before. I saw a company last month that, their only core focus is to prevent data breaches from people. Let's say a self-driving car, it's driving and it's reading, a stop sign, and they're actually the hack is to put a speed limit sign on top of the stop sign. So it's actually polluting the data source. So then instead of slowing down your car, like an autonomous vehicle, it's actually polluting the data to read it as a speed limit sign, which it causes it to accelerate. And that's stuff that we've never seen. And I think that healthcare, the issue that concerns me is we are moving really fast, and we have to, because COVID demands it, and the health of millions is at risk. But these hackers are moving at the same speed and doing things just for the joy of it. And at one point, I think that that will slow everything down at the same time. So it's kind of like balancing the innovation speed and then trying to catch up with how innovative people are at polluting and hacking these algorithms, which are actually unknown and black boxes for very many people in deploying them.
And of course, when it came to self-driving cars, to use your analogy, if there was one death of a self-driving car in Arizona, that was international news. Obviously, the stakes are much higher when you're dealing with healthcare. So, Dr. Razak, how do you, those challenges of deployment, but also security? I'll kind of move into the security advances here and maybe have you answer both. How do you integrate this stuff in, and then how do you make sure that it's secure?
Yeah, so our research group has thought a lot about the security problem. We are the leads of the largest hospital data network in Canada, holding data on hundreds and hundreds of thousands of Canadians, very detailed clinical data, so billions and billions of data points of health data. And so that data is not consented. We don't ask permission to use that data. So you need to be very, very careful about security. The reason it's not consented is that when you're talking about the hospital sector, an important percentage, perhaps one of the largest groups within hospitalized patients, could never give you consent. They're so sick from what they've come into hospital with, or they have advanced cognitive disorders like dementia, that they can never provide consent. And so there's been an agreement with research ethics boards, et cetera, that you can get access to unconsented data if you really want to describe the health of Canadians and not miss some of the most vulnerable groups. So we passed that bar, but then the question is, how do you protect the data itself? And we go through extensive processes of removing identifiers before data ever leaves a hospital's firewall. And we use encryption algorithms that will transform linkage markers. So things like a health card number, we'll convert it using what's called a hash algorithm to a unique ID that can be used to track patients through the system, but could never be used to backtrack that patient to figure out who they are in the first place. So we take steps like this, and then you go through formal processes like going through threat risk assessments and having firms that are trained to detect weaknesses in your privacy approach, look for problems in your data holdings, and then it goes under audits repeatedly and repeatedly. So there's a sequence, but I think at a broader system level, the question that Canadians have to engage in is, do we accept that there will be breaches and accidents? It's inevitable that it's going to happen. You know, an analogy would be you set a speed limit on a highway. That speed limit is chosen to give you a certain amount of safety, but you know that accidents are going to occur. And as a society, we accept the trade-off between being able to commute at a certain speed versus the risk of an accident. There's enormous benefits to having this kind of data integration and using it for individual healthcare delivery, system planning, cost efficiencies, looking for inequalities in care, but they will be problems. So every system that's had this kind of data, eventually there's examples where you can re-identify patients, even though you do your best to avoid that. You know, a famous example is within Boston during the Boston Marathon bombing. They were able to re-identify some of the patients who were hospitalized because they could link newspaper reports to say that an individual of this age had severe damage to their leg and was rushed to hospital. And then they look into the hospital records and they see an individual of this age comes in with a leg injury, and suddenly they can figure out who that person is. So there's examples like this that we'll always face. But I think that is a broader societal question. Where do you take the risk-benefit balance? And I don't think it's been explored well in Canada for sure. And I don't know of great examples internationally where people have really come to an agreement about what's acceptable.
It's a wonderful framing. Do either of you want to jump in on that?
Yeah.
So
I think that Fahad, you mentioned that this point about risk, and then I think there are best practices that definitely exist. You mentioned the encryption, and then a bunch of security guardrail, identity and access management. So I think there's definitely a systematic sort of best practices you can implement and get going. But I think it's so important that you pointed out that it has to be risk based, right? Not all data are the same. And and then this is perhaps a really great point that for a lot of AI development, you don't need a patient identifier. So there are tons of things you could do, including de-identification as part of sort of systematic process to scrub. And of course, in some of the use cases, you might sort of get into more of a granular level of patient information. So I think that, there are many different use cases that exist. And then just kind of looking at it from that risk-based, perspective, right? So really understanding, hey, what type of data? I'm talking about that idea of data classification here. There are tons of sort of work that's been out there in terms of framework, including the ones from federal government, right? So really understand the risk here based on data classification, and then really understand what are the guardrails and the best practices that are needed to really secure that, that type of data, and so I think the risk-based approach will really serve us well. Otherwise, it's very, very challenging if you have to treat like de-identified data with everything you've got. I mean, from cost perspective and and effort perspective, that's very, very challenging. So I just wanted to point out that the risk-based sort of perspective, and really understanding that risk, I believe that serves us really well from the enabling a lot of this innovative effort.
We have we want to go to audience questions, and if you have more, please do submit them. I just quickly want to read the room here. These are complex, nuanced, and sometimes frightening issues. And I think back to the e-health scandal in Ontario and how, in my view, that may have set back difficult conversations, because it became a third rail, a political third rail. As of now, would you say in each of your respective areas, I mean, even just give it a grade, where are we, a lightning round here, in terms of having these conversations where you feel we need to be versus where we are today? Why don't I start with Katie?
It's funny. I was going to say, actually, I think the other two are better placed as to the federal and the data, especially on healthcare. There's always going to be a risk. I just want to answer on the piece of Farad, what you said. I think as Canadians, or even the media, I was thinking, David, you could be, how do we make explicit some of the expectations or the risks? I think, we hold, AI or other things to this, holy grail grade, like to your example of the car crash, in Arizona, one car crash and the whole test was down, but how many cars crash all the time with humans behind it, and I think, the benefit of a lot of these, AI systems are going to be best for the general public. We just can't make a spectacle out of the 1 or 2 incidents that do occur. And I think, how do we be more explicit in managing the expectations for all Canadians, or all public actually, to say, okay, here's the risk, and it will be 2 or 3 like incidences, but here's the greater good. And then when those things happen, it's to recontextualize it within the scope of like, here's the greater good that has happened. I just want to comment on that, because I think that sometimes the public outcries on these things really slow innovation down and cripple great projects because they didn't have a great PR person on the team, So that's my little comment, but I'll let Fred and Soin talk about more.
Okay, so you weren't willing to give it a grade. I'll count you down as a B- from where we are in Delta. It is interesting, whose job is it to do that is a whole other question. Is it, leaders' job? Is it medical professionals? All of that.
And AI governance is new. Like, I'm looking at all the policy. We had a policy department at Element AI, and that was brand new. And we were being solicited in Europe and also Asia to consult on that policy. And like, having been to not Capitol Hill, but to Ottawa, talking to a lot of the MPs, like, they have to make decisions on stuff they barely understand. Unfortunately, that's not their area. So it's very interesting about like who's going to drive that policy, which will impact significantly how healthcare and AI are going to, work in symbiosis together.
So, Ian, I'm sure you've sat across the table in many of these types of conversations. How would you grade the understanding or the willingness to accept that there is that delta between 100% success and everything else?
I think that people understand there's definitely a gap, and then just to kind of speak to that, the governance front, and then the fact that I see the governance. It's not as in it's a ton of brick and you have to do this, and privacy, security, here it is. So as a barrier, but I very much see governance as an enabler. So it's both fronts. It's not just the technology, security guardrail, automated de-identification process, but it's also the people and processes, right? And I think people kind of recognize that we need to kind of work on both fronts. So, do we understand that there are gaps, and then next step to really, help all of us innovate? Yes. Certainly that's true in BC. Providence works very, very closely with as part of the ecosystem. And then, for example, Provincial Health Services Authority, with whom our close partner, a lot of foundational data operation, we collaborate very, very closely with them. So yes, collectively we recognize there's a number of gaps, and governance is a hugely important topic, considering patient safety and privacy, absolutely. But we really see that as an opportunity and as an enabler by having the people and processes, right, in addition to the sort of the some of the systematic and solution that we can leverage by use of technology.
Okay, great. We have an audience question here. Would panelists comment on the need for explainable AI, i.e. white box versus black box, example, neural networks, used in healthcare in general and in medicine in particular? Who wants to try to do that? Doctor, you want to take it? Also, maybe you could explain for a Luddite like me what the heck a white versus black box AI is in the first place.
Yeah, I can give you the clinical side, and I think probably Katie and Soyin would have some interesting insights on the deployment technology side. So from a clinical point of view, why white box versus black box matters is that white box means when you're making a risk assessment, let's say, for a patient, the factors which are driving your risk assessment. So if I say, this patient that I've admitted with COVID is very high risk for deteriorating, I'll say that's because they are from long-term care, they're a certain age, they have diabetes, and they have high blood pressure. So that's an explainable link between what they have and what I think is going to happen. AI decision-making will not follow that paradigm. So you have a lot of variables that go in and outcomes of prediction for risk. By and large, there are ways to make part of it explainable, but by and large, what we're seeing in these models is that there is a direct link between risk factors and then outcomes. And that is okay in the clinical space. That's not a problem. A lot of what we do doesn't have a direct XY relationship. When we do an assessment of what we're seeing on an image and we link it to an outcome, that's not always because of thing A, B, C, or D, and we still have some kind of global assessment of what we're seeing. The barrier to a physician using this, though, will be that proof that this unexplained model, the black box model, gives you reliable prediction. So that's an evidence question. So if someone says I have a black box model that works really well, I would say as a physician, show me the evidence, show me which patients you developed it on, show me on an independent data set that it's working just as well as you think it's working. I would then be more open to using it at the bedside.
Well, I want to skip. I want to ask you another question, if that's okay. I want to get to as many of these as I can. Thoughts on data trusts as models of data sharing that could open up more data, sharing with small businesses and entrepreneurs in the health space. And then there's a question about making sure that healthcare is ethical. I think we've kind of touched on that a little bit in terms of how we explain a lot of this stuff and thinking about through it. But in terms of data trust as a model of data sharing, Katie or Soyin, do either of you want to jump on that?
Sure. I think we kind of talk about governance. Katie and I kind of speak to that. I think there's a number of things we talk about in terms of governance. Just having the people and processes. If something went wrong, do we have an accountability structure and people can understand that, as well as some of the systematic guardrail that we kind of discussed as part of leveraging some of the latest or best practices technology, right? So I think more we kind of have those the governance in place and then communicate that out in transparent manner, and then more trust that we can build as collectively together. So it's not that just like hey here's the data and then trust us, right? But just being able to kind of point out, here are some of the processes that we put into place. Here are the people who are responsible for this data operation and some of the security guardrail, and here are some of the best practices we have implemented. I think it's just that speaks to all of us that all of us, especially as a data steward who are dealing with very sensitive patient information, we need to demonstrate that the data stewardship and how we actually do it. So I think that those are an important point in terms of establishing public trust.
I'm also seeing kind of requirements. I think the data trust piece has to be a third party. So you think about social media, like, oh, trust us, we'll govern ourselves, like the Facebook governing themselves on, all the stuff. And I think more and more and especially in healthcare, it needs to be a third party authenticator with regards to regulatory compliance. So when I talk about, and I completely agree with Soyin that like governance of AI is super important. It is a facilitator. It needs to work in collaboration. And it's not there to impede the innovation. I just want to clarify that piece. That it is actually to accelerate it, to make sure that we know what the guardrails are. And more and more, it's not about and we see this in banking. So, big banks, they have their own AI arms. They're doing their own governance with regards to their own algorithms. And more, we're actually seeing that there is actually a third-party government requirement for them to have a third party come in, kind of like audits. You know how you have the big four that audit come in. You don't want just the company to report their own books, but you want a third-party auditor that will authenticate that these things, and we're seeing that with algorithms, that they actually run the gauntlet through and to see, are there biases? And what's interesting, I've seen recently, actually, you strip out age, for example, bias. We talk also like gender bias or age bias for other certain things. Well, you know what? Other correlated items. So you know what? Like younger people happen to live in apartments more than homes. So if you have that other node and you didn't strip that out and you're not looking at other causal variables, you might, through two variables, introduce a bias or another issue. And I think more and more we are actually seeing that requirement on regulatory. So the data for me on sharing, and that's where specifically the question on SMEs and entrepreneurs, that's where it's tricky, like, because you barely have enough teams to kind of deploy, which takes a lot of effort. And now you have to like have the burden of proof to authenticate. So I think we're going to see an emergence of startups or the companies that are going to act as third-party authenticators or regulatory, which will, I think, bring a level of maturity into AI algorithms, which I think will be welcome.
It's incredible how much of this conversation is taking place in other sectors as well. I think immediately of fintechs. And obviously, all you needed to see was Robinhood last week with GameStop and some of these questions and open banking and how these things all interplay together. Dr. Razak, you wanted to have a brief comment on interaction with industry on data access.
Yeah, I'll just mention briefly that because there isn't an accepted framework for how to interact with industry for this kind of data, these large samples of Canadian health data, the default position is to not interact with industry. So if you look at the example of what happened in the NHS in the United Kingdom with Google, obviously an enormous amount of criticism about their data sharing and led to essentially the end of the relationship between the two entities for broad applications. There's a real risk here in Canada of the same thing happening. So if you look at large data repositories in Canada, and ours would be one of the largest in the hospital sector, because there's not clear guidance on how to interact with industry, we don't interact with industry. So we have models for any established government researcher, nonprofit to access our data to do analysis on it, but it can't be done by an industry partner for something that can be deployed for profit, because we think that would not be an appropriate use of the data right now, given the current environment in Canada and the fact that this data is not consented.
All right, we only have a few minutes left here, so one last question to go around to all of you. The title of this talk was AI's role in a post-pandemic healthcare system. Looking forward, from each of you, if you could have a wish list, you have your soapbox right now. This is it. There are people listening, I'm sure, who have a lot of influence because they're logic readers, and all logic readers have influence. What would be the one or two things on your wish list that could carry forward or that you need in order for this to be successful post-pandemic? So Yin, I'll start with you.
I think we talk about regulation and then really understanding what's involved in terms of, deploying AI and then putting it into clinical use. I think there's certainly, I like to see more of that, and then more company, and then, more partners and then people working in that space. So I think compared to sort of US, I think in Canada we have, the handful of sort of AI sort of project. So definitely, I think that's an area that more people can get involved, and then just have a clear process so people understand what's involved in terms of deploying AI. I think that's going to be really helpful. Partnership is more better, and I think Providence is very uniquely positioned in a way that we're a founding member of the Digital Supercluster, which is a pan-Canadian initiative in terms of establishing an innovation hub on precision medicine. So naturally, we work with a broad stakeholder, including academia as well as private partners. So we talk about the private and public partnership, and then we're very much in it. And then we talk about that investment, and then we're making on some of the foundational data operations. So I believe that's going to be very useful and something we can continue to capitalize on for the benefit of our patients here. So we'd like to see more of a partnership happening, and then co-development, and then co-deployment. Lastly, AI ethics. I think that some of the panel members touched on that. I think that's a really important point. I mean, healthcare in particular is a very human-centric domain, and then we have to do everything that the deployment of technology. We're doing it in an ethical way that will benefit our stakeholders as well as the patients. So I think the ethics side of things, it's a topic that's not well understood. So I think more education is definitely needed, and I think that just having the queries and then the question from patient, I think that's a really helpful thing, especially to try to bridge that gap between the developers themselves and then the end users or patients or staffs or clinicians, just to get that feedback. If you feel like, hey, how is my image being used for this monitoring process, for example, right? I think that's a really, really good question, but it's just more people ask that question, more people want to get involved and know more, especially around AI deployment. I think that's really helpful. So I think that some promotion and education is needed, certainly, try to understand and then get more people involved as part of the ethical AI deployment process.
Terrific. Thank you. Dr. Razad, like all physicians, has to run to his next meeting. So you get to go next, and then we won't be offended if you rip off the headphones and take off.
Okay, thanks so much. So first of all, a really great opportunity to speak to Katie, Soyin, and you and David. I really appreciate it. I'll say a lot of my feelings on this have been covered. I think the major barriers, I'm optimistic for AI in medicine, actually, despite some of the limitations I've highlighted. The major barriers that I see right now are data integration and the connection to frontline care delivery. So bringing the relative data sets together and then making the prediction tools accessible to a frontline physician. That's the technical barrier that I see, and then the cultural barrier. So I think Canada really needs a framework for understanding risk benefit, accepting risk, and not piling on examples like the Arizona car crash, because there will be examples like that in the healthcare space if we allow data integration and uses to accelerate. And we have to accept that the broader benefit is going to be so significant that it's worth it, and that we'll learn from these examples rather than make them the mechanism to stop these initiatives.
Terrific. Thank you for joining us. Feel free to leave. We'll take it from here. Katie, your wish list.
I think it's very much in line with what Far just said with regards to like, how do we, so I'm obviously coming from the private sector, especially funding ultra private through my VC work at Real Ventures. And there's two things. It's how do we make those data sets actually more available? Like I love open source AI, a lot of the stuff that we used to deploy, we would put it up on GitHub and make it really accessible. People could rebuild a lot of the stuff that we did. And I think that data is fundamentally the source of innovation. So how can Canada be a leader in that by, taking off the PII or the personal information and scraping all of the identifiers and make those data sets public too? Really, we have an amazing ecosystem of startups and entrepreneurs in Canada, and more we're actually retaining them. We're not just, we used to talk a lot about the brain drain, and now, it's not draining as much. Like Canada's retaining that. So how do we leverage all of the work that CFAR has done and all the investment that we've made and all the schools in AI? We got to feed them. We got to feed them data. So the thing is, like, how do we actually make that would be my hope, to not stint that innovation in healthcare, especially because, like no other place on earth, like, Canada has this amazing healthcare system that's federal, provincially regulated, and all the data is coming into us. So we actually have the choice as a government level to provide it. It's not independent, for-profit units that have that data kind of sourced to themselves. So I think Canada has a real ability to lead and provide those data sets to innovate, not just here, but abroad as well. So that would be my number one wish. And also the number two is that, media doesn't turn it into, sensationalism and when things do go awry, because they will, as we push the frontiers of things, which I hope that we do in Canada, we're going to have to accept some of the risk. And governance, ethics, and AI, making it explainable, all things that I think are being worked on and top of mind. But at the same time, there's a risk and a reward that we have to consider.
Well, terrific. Feed them data. It's a wonderful sentiment. We at The Logic, we don't feed you data. We feed you conversations like this one. And it's been an absolute pleasure to talk to the three of you today, Stoyan, Katie, and Dr. Razak. Thank you so much for this. I also want to give a shout out to Microsoft for facilitating this wonderful conversation, and to Dr. Helia Mohammadi, who also had to jump off. These are all very busy people, as you can tell. We're grateful to all of you. Just an acknowledgement of our next talk. The Logic holds these. For those of you who don't know us, we hold these talks regularly. Our next one will be on Wednesday, February 10th at 12 p.m. It is with Kevin Carmichael, and it is titled Econ 101. All the things you've wanted to know about the Canadian economy, but were afraid to ask. There are so many things happening right now, whether it's GameStop, whether it's deficits and fiscal anchors, or the pandemic's impact on business. And we will spend some time walking through it all so that you don't have to be embarrassed at your next virtual coffee party and can have a wonderful interaction understanding economics. So subscribe to The Logic, and you can be a part of that wonderful conversation. On behalf of everybody involved in this production, John Packman, the producer, Amanda Roth, Carolyn Mercer, Jenna Meisner, our folks at Veritas and Microsoft Canada, thank you so much for joining us, and we'll see you again soon. Bye-bye.